Okay, Ravens, part two of pressure injuries. We've talked about orthostatic hypotension, and now we will move to pressure injuries. So, as we talked about in the first episode of the first recorded lecture about positioning, there are various positions that patients find themselves in where pressure on bony prominences can cause trouble with skin. So obviously you have that pressure on, say, the sacrum in the supine position, so there's decreased circulation there. And the reason for patients staying in one position too long is decreased endurance, decreased strength, and sometimes decreased cognition to realize that they need to change positions, and so all of these can lead to a pressure injury. So we talked about um, in the previous PowerPoint, we talked about in the different positions, supine, side lying, prone, which areas are at risk. Generally speaking, 95% of all these pressure ulcers or injuries develop over these five locations. I just slapped the table, sounds like an exam question to me. Sacrum, coccyx, greater trochanter, ischial tube, heel, calcaneus, and lateral malleolus. So those are the top five contenders for pressure injury locations. So the way pressure injuries can progress, and basically it's just uh, going deeper, involving different layers of tissue. So here we just have a real general discussion of or illustration of the different layers. So first there's the skin, the dermis, then we have fat tissue, muscle and tendon, and bone. And so that's kind of how pressure injuries are staged or described, is kind of based on what layers of tissue are involved. Um, so in general, as I said, they are often called also decubitus ulcers, but it's basically a lesion caused by unrelieved pressure. And so there's four basic stages. The National Pressure Ulcer Advisory Panel that has done that. So stage one, by non-blanchable, that means uh, typically if you put pressure on someone's skin with the distal end of your finger, you'll have some whiteness, and you remove the pressure and it returns to the normal skin color. And so in this situation, that redness or erythema is not changing. So the skin is intact, it looks red and swollen, and the redness is not going away. And so you take away the pressure. So maybe in this case, you have a patient who's spending time in the supine position, you roll them to side lying, and you notice in the area of the sacrum, there's redness. And now that they are no longer lying supine with pressure on that area, the redness does not go away. And so that prolonged sustained redness is basically the definition of a stage one pressure injury. And so it is basically involving the epidermis. It's not going to the fat layers or anything below the skin layer. Stage two, this this area, we'll stay with the example of the sacral area. It looks like a blister, it's peeling. Maybe there's even an indentation. It looks like a scratch. And so often now we're through the skin, so it looks like a sore or a scratch. And there's pinkness or redness. It's moist. And obviously something has changed with the skin. So we're below the epidermis and now we're through the dermis. So that first layer of skin has been violated, and it either looks like kind of the beginning of a sore or a blister, but that first layer of skin has been changed. Whereas in stage one, there's just redness, but the skin is intact. So stage two, the skin is no longer intact. We get to stage three, now there's depth. So there's a crater, there's undermining and tunneling can mean that you're looking at, say, the size of a dime, that coin. That's the opening that you're looking at. Often, uh, what you can't see visually is the hole goes deep and maybe extends to the left side or the right side. and that's undermining and tunneling. So sometimes it can be worse than it appears on the surface. And now we are down through the fat layers to fascia, muscle, tendon, ligament, um, can be involved. So I'm sorry. So we're not to those layers. They're not exposed. So we are just through epidermis, dermis, and through sometimes the subcutaneous fat. That's why some of these pressure injury areas are most susceptible, like the sacrum and the calcaneus and so forth, because in those areas there is very little subcutaneous fat, and so you very often you get right through the pressure from a bony prominence goes right through the skin and causes the injury more readily. So then stage 4, again, a deep crater, underlying tissues are affected, and now we're all the way to muscle or bone or fascia. We're through both layers of skin, through the subcutaneous fat, and we're to uh, uh, deeper tissues like fascia, muscle, or bone. There are other injuries that are unstageable, and so there are eschar is like blood clotting that is, or scar tissue that is developing. So maybe the area was starting to heal, but then the pressure continued, or the lack of circulation, lack of nutrition, and so there's layers of skin that are sloughing off. There's some of that eschar in there, and by definition, then it is unstageable, because often you cannot see how deep the area may go. And so visually looking at it, it's impossible to tell. So now we move to this slide has a lot of information on it that I won't read to you, but you can read through some of the different criteria or just things that are happening, the sequelae, the results of a pressure injury. Uh, and as you will imagine, there are many underlying factors that put a patient at risk for a pressure injury. Of course, the first issue we've talked about is just the fact that they are not changing positions. They're weak and deconditioned. They're obviously very sick. Perhaps their cognition has been affected. Perhaps they're sedated. Also, very often, what happens simultaneously with patients in this situation is that they are malnourished. Perhaps they have decreased cardiac function, so their blood circulation is insufficient. They don't have the nutrients that they should, that would assist with uh, wound healing. And so all of these factors combine, sadly, to make the situation more likely and progress more quickly. Um, so these are some examples of people who are at risk for pressure injuries. If someone already has some violation to the tissue over a bony prominence, as we said, one of the risk factors for a pressure injury is a previous pressure injury in an area, but it also could be after a fall. And so the skin was damaged by the greater trochanter, for example, or the sacrum. And so now, because that skin has been compromised, then sustained pressure in that area will be more problematic. Obviously, if a patient is chair or bed bound, and so they're not up and moving, then that's going to put them at risk. And then the next slide talks about risk factors for pressure. So decreased mobility, their circulation is insufficient. As we talked about in the first PowerPoint, skin changes with aging. Skin becomes less extensible and resilient, and obviously decreased sensation. If a patient is not aware that an area is getting some pressure buildup, then they will not likely change positions, and they're at greater risk for a pressure injury. We talked about friction. We talked about when helping a patient move, change positions, we want to lift and move and not drag them so as to decrease friction and shear on the skin. We also want to be very aware of moisture. Moisture can accelerate quite significantly skin irritation and then breakdown. And often that goes hand in hand with incontinence. If a patient is bed or chair bound and incontinent, now you have urine and or feces in an area, or also in Arizona, patients can be sweating quite a bit. A patient who is obese is going to have skin folds where moisture accumulates or is present over a lot of time. Moisture can definitely accelerate the process. If their cognitive status is insufficient and if they're malnourished, all of these can be risk factors for pressure injuries. This is the Braden scale, which is used um, to kind of assess patients and basically assess the risk for predicting pressure injuries. And so we won't go through this in detail, but please familiarize yourself with it. It talks about sensation, moisture, their activity or positioning, their mobility level, their nutrition, and friction or shear. So for a lot of patients in the home health setting or in the inpatient setting, this Braden scale is utilized to alert all of the staff who are taking care of this patient for the relative risk for pressure injuries and skin irritation. So the things we try to do to look at the risk factors and address them. If somebody is not mobile, they're inactive, and they don't have sensation, then we are going to uh, position them, kind of change positions for them. We're going to use pillows, we're going to move them from supine to side lying, and then back to supine, and then perhaps side lying on the other side to relieve the amount of time that the skin is in contact with these bony prominences over time. If they're malnourished, then of course we're going to try to address that with supplements and improve their nutritional status. Uh, Again, if there's friction and shear as a risk factor, for example, the patient's weak, and so when they're trying to scoot in bed or roll over in bed, they tend to drag themselves. We're going to assist them using a draw sheet and try to eliminate that friction and shear. Obviously, if somebody is incontinent, we're going to make sure that we are carefully monitoring that and changing their depends as needed, applying products to the skin, such as like Desitin for a little baby, what that basically kind of has an oil base that keeps the skin away from that moisture and protects it. So in general, prevention of pressure injuries, we're going to change positions often. We're going to relieve pressure. We talked about that in the first presentation as far as bridging the gap and dispersing the pressure over a larger area instead of one bony prominence. Of course, as physical therapists, we're going to try to get our patients moving, get them up out of bed, even sitting in a chair, starting to walk. All of those have a multitude of benefits, but definitely benefits the skin. We're going to be frequently looking at and monitoring skin integrity. When we're in this inpatient setting and we're doing an evaluation with the patient, we're going to, as we're assessing, for example, bed mobility, are they able to roll to their side? As they roll to their side, we're going to be looking at the sacrum and making sure there's no redness, no skin breakdown. We're going to be aware of their calcaneus and so forth, these different areas to make sure that there is no areas that are at risk or already having problems. Um, Obviously, we're going to try to control moisture and promote nutrition. Uh, so this is kind of a general idea. As a minimum, patients need to be changing positions every 2 hours. At the beginning, when we're first getting to know a patient, we're going to, and it's not just physical therapy, occupational therapy and nursing will be involved in that inpatient setting. As a team, we work together to be aware of a patient who may be at risk from a skin standpoint and try to communicate that and uh, intervene as necessary. Obviously, we're looking at their vital signs. When we're documenting anything that may be related to pressure injuries, we are going to be making sure that we're documenting their vital signs, but also the location of a pressure injury. We're going to stage it. If somebody was ever at a stage 4 and now it's improving, we're going to always, once they've been to stage 4, they have a stage 4 pressure injury, and then we can talk about how it's improving, but they're always a stage 4. Of course, the size, length, width, depth, often there are photographs that are used in documentation, and if there is drainage? Is there an odor? How much? Are there other signs of general infection? Thank you very much.